Really thanks for coming down for this Bisofarm Symposium. Uh, the first lecture is from Dr. Rizwan Ulak on curious case of beta blockers. Sir is well, as you know, Sir is the well-known cardiologist, and he has done his DM card, and he is the chief consultant and interventional cardiologist at Yeshodhara, and he is the chairman and chief consultant at Apex Hospital also. So I request him, please come on the dais and take the sessions.
Good evening, dear friends. It's been privilege to be again in front of you all after long COVID times. Today we are discussing about beta blockers. I wanted everybody to know about the present status of beta blocker. What is the present status of beta blocker in our day-to-day practice? I want each and every one of you to go out of this hall with a concept which is very clear: when to use, how to use, when not to use. These 3 points should be in your mind. Today we all are using beta blocker inappropriately, what I feel, in our daily day-to-day practice. To quote the history, beta blockers were discovered by Dr. James Black. Who is he? He is a pharmacologist. It was discovered way back in 1958. So it has got a long history. And for this molecule, he was awarded Nobel Prize in 1988, almost 30 years after the discovery. And that was the era when beta blockers were booming in clinical practice. And you see a lot of beta blocker trials and all from 1980s, 1990s and early 2000. Today things have changed. To understand beta blocker, we should understand where does it act, how does it act, what does it does to our body. I would like to show you this flow chart. Our nervous system, which is very well known to us, central and peripheral. In that peripheral, there is something called autonomic nervous system. In this, we have two control systems, the parasympathetic and the sympathetic. This is, we all know from our MBBS days. The parasympathetic nervous system is controlled by acetylcholine or cholinergic pathways. Whereas the sympathetic nervous system is the one which is the adrenergic pathway. So what is adrenergic pathway? Adrenergic pathway is a sympathetic nervous system which has got an autonomic control. To make it more understanding, are they same? What does they differ in body? How are they innervated? Which part of the body is controlled by which system? And similarly, the side effects will be there. So this is a graph to show, this is a diagram to show the sympathetic and parasympathetic nervous system. They act on various parts of the body. The sympathetic nervous system controls fight or flight, while the parasympathetic nervous system controls rest and digest response. These are the 2 points which should go in your mind before going from here. The sympathetic nervous system, fight and flight, that is emergency situations. The parasympathetic system, the rest and GI tract. That's all is matter of concern. To give an analogy, what is sympathetic and parasympathetic? The accelerator is just like sympathetic. The body rushes. Whereas putting the clutch is parasympathetic, where we need to take rest. What organs it innervates? It innervates lot of organs in the body, from the eyes to the glands to the lungs to the heart and to the GI tract. So that's how the body maintains sympathetic and parasympathetic nervous system. In sympathetic nervous system, these actions are through the receptors. They are called adrenergic receptors. What are these receptors? They are alpha and beta. Alpha are predominantly taken care by norepinephrine, noradrenaline. Beta are taken care by epinephrine or adrenaline. Although there is a mix of these things, predominantly I am using the word. So where are these adrenergic receptors located and how they are classified? I told you alpha and beta. Today the concerns is of beta blockers. So we are talking about beta blockers. We have beta 1 receptor, beta 2 and beta 3. Alpha receptors is not the topic of discussion for today. Where are they situated? Beta 1. Beta 1, it is said 80% of beta 1 receptors are in left ventricle. That means beta blockers by and large B1, it is we are talking about the heart. The beta 2 receptors, maximum receptors are located in the blood vessels and the lungs, bronchus. So these are the 3 points which you should take from the receptors. The heart, B1, B2 is from the lungs and the blood vessel. B3, adipose tissue. There are some uses and all those things we will, if needed, we will go through it. So after seeing the history of beta blocker discovery to the use, to the trials and in various the reports, beta blocker were introduced as anti-hypertensive drug and they were predominantly taken by the mainstay as treatment for hypertension in various joint national committee reports. JNC 1, 2, 3, 4, 5, 6, up to 6 beta blocker were as first line anti-hypertensive drug. But things started changing from JNC 7, 8 and all those things. Now it is no more as first line drug which is used. In beta blockers, there are older generation, the second generation and the latest, the third generation. What is this got to do with us? Yes, the first generation were basically non-selective propranolol-like drug. Still today it is used, but used in specific conditions. The second generation, they are very specific, they are beta-1 antagonists. The examples are metoprolol and bisoprolol. The molecule who have organized this CME is bisoprolol, today's molecule. Let us see where it stands in our practice of day to day. The third generation, apart from the beta 1, it has got even some alpha property. And there are additional properties like antioxidant, anti-angiogenic, anti-proliferative, anti-hypertrophic, anti-apoptotic. These are all considered as endothelial function activities. So they are beneficial at large. So these are the recent molecules, nebivolol and carvedilol. They are used very rampantly in cardiology whenever needed. Coming to the use of beta blockers in India, it is said to be that it is the third line recommendation in international guidelines for hypertension. It is said to be third line. I will show you a slide where it is no more in line. It is out of line in hypertension use. Nobody is using beta blocker in hypertension management, whereas other indications are still good enough. If you see the prescription in America about top 10 beta blockers, metoprolol and carvedilol are top 3 in prescription. Where is bisoprolol? It is the 10th prescription after all these drugs. So don't be under this impression that Bisopharm has organized this CME, so it is the molecule to be used. Where does it stand in our practice? Let us see further. What were the early indications in 1988, 1990s and all? They were very classical in angina pectoris, heart failure, atrial fibrillation, acute coronary syndrome, hypertension. 5 indications for beta blocker in olden days. They were less common like in prevention of migraine, hyperthyroidism, anxiety neurosis, tremors and glaucoma as eye drops. These were the indications for beta blocker in olden days. After the trials in beta blocker, not less than 80 trials were done in beta blockers. We came to know additional indications like aortic dissection and hypertrophic obstructive cardiomyopathy. These were added on. But presently, we have almost 22 to 24 indications for beta blocker in today's practice. By and large, angina pectoris is the number one choice. Atrial fibrillation, it is used to reduce the ventricular rate. Cardiac arrhythmias, it's a very good antiarrhythmic agent. Congestive heart failure, it is one of the drug in the 4 pillars of heart failure management. Essential tremors, we all know that benign essential tremors come down with beta blocker or alcohol. Glaucoma, it is used by our ophthalmic friends very frequently in the form of drops. Hypertension, this is no more a top more indication for use of in clinical practice. Today we are using in hypertension only and only if this is associated with any of these things. Isolated hypertension, we rarely use beta blockers. Hyperthyroidism, migraine prophylaxis, mitral valve prolapse, myocardial infarction. The standard recommendation in myocardial infarction, whenever you see a ST elevation MI, give 2.5 milligrams of beta-lock injection. After 15 minutes, if needed, the heart rate is not in the range of 60 to 80, another 2.5 milligram. The targets were achieved and that's how the lives were saved. Lot of trials are there for beta blockers in acute myocardial infarction. Additional postural orthostatic tachycardia syndrome, the POT syndrome, it's nothing but cardiac autonomic neuropathy which we are talking about. The symptomatic control, like in tremors, hyperthyroidism, we all know that propranolol is a better drug. Theophylline overdose, beta blockers are used. Acute aortic dissection, there are certain beta blockers which reduces the pressure, central aortic pressure, and they are the initial drug of choice for treatment of aortic dissections. They do a wonder. Hypertrophic obstructive cardiomyopathy, very high dose beta blockers are needed in the management of HOCM. Long QT syndrome, especially the congenital long QT syndrome, still today beta blockers are one of the good drug of choice for that particular condition. Marfan syndrome, I already told. Prevention of variceal bleeding in portal hypertension, this is again subject of debate. This is responsive only in 70% of individual. Propranolol, which we commonly prescribe for ascites, portal hypertension, only there are responders up to 70%, 30% are non-responders for this drug. Possible in hyperhidrosis, you may get patients who have got some palms and soles with sweating. There also beta blockers have been tried. Anxiety neurosis, it is a common co-prescription which is used. Controversially, there was one indication which was previously very well documented, that is perioperative mortality reduction in non-cardiac surgery. We used to give beta blocker, 25 milligram metoprolol, 12.5 milligram metoprolol. We thought that it will prevent arrhythmias, it will have reduction in all-cause mortality, but today we are wiser enough, this has got more side effects than beneficial effect. Immediate post-operatively, these patients tend to develop hypotension, which is more dangerous than the protection given by beta blocker. So today it is not recommended for all patients. Only when indicated with other compelling indications, we tend to use these drugs. Once we know indication, we should know also about side effects. Most of these patients who are on beta blocker will come with these side effects. We try to pump in some other drug to take care of them rather than withdrawing the beta blocker or adjusting the dose. That's the commonest mistake we do in our practice. Dizziness, tiredness, blurring of vision, cold hands and feet, especially in ladies, slow heartbeat. Elderly patients are very prone for slow heartbeat, and nausea, diarrhea. Less common side effect, disturbance in sleep. Commonly these patients may come only nocturnal night sleep disturbance. Nowadays I am not getting sleep. You may not be knowing it is beta blocker which is a problem. The sexual disturbances, all of us know that it not only causes erectile dysfunction, it also decreases the libido. So beta blocker, whenever you are prescribing to a sexually reproductively active person, you need to ask. In life we have seen everybody is active, nobody is inactive. Don't consider inactive. Ask them proactively. Unless you ask, they are not going to tell you. What is this? What is that curious case which we are talking about in discussion? Today we are talking about something called India is sitting on a ticking time bomb. Why? Post-COVID, we have seen a lot of patients have got tachycardia. What is this tachycardia? Why is this tachycardia? Still we don't know. Is it still the post-viral tachycardia? Still we don't know. Or the COVID virus had effect on our autonomic nervous system? Still we don't know. Or it is our lifestyle which has become, we have become tachycardic? Still we don't know. But this is we have seen. It is simply said as sympathetic overdrive, higher resting heart rate in young, underlying anxiety and restlessness. These are commonly seen in today's practice. They are more so seen in Indian population. There is a systematic study done in Indian and Western population. Indians have outgrown in these numbers. It is said that 62% of patients have sympathetic overactivity, which we are not aware of them. So what are the parameters to see for sympathetic overactivity? Definitely patients are restless, they have got inappropriate sweating, they have tremors in hand, they have fast speech. These are some classical things which in your OPD you can diagnose for such situations. So what are the factors Deciding sympathetic overactivity in young Indians, it not only causes the sympathetic activity, beta adrenergic drive, it causes rise in heart rate, rise in systolic blood pressure, both or none. So all will not develop, but 60% will have this type of presentations. So we all know that sympathetic nervous system affect these organs initially. What are the effects on kidneys? The sympathetic overdrive will increase the RAS. We all know that RAS is the main culprit for hypertension and CVD. CVD means cardiovascular, cerebrovascular, all disorders. RAS is considered to be the main reason for this particular situation. They also tend to develop resistant hypertension. In resistant hypertension, we have done trials. Today, we all know that beta blocker has got no role in resistant hypertension. It is diuretic which has got more role in resistant hypertension. So, first drug of choice which you should get in your mind for resistant hypertension is diuretic, not beta blocker. From hypertension guideline, beta blocker is just moving away and away and away only. In this sympathetic overdrive system, we have found out young individuals constitute almost 1/4 of them. They tend to have very high heart rates whenever they visit to our clinic. Not only the heart rates are high, even the blood pressure monitoring is also high. It is on an average found to be 80 plus. If you see in different countries what is going to happen with these young hypertensive patients, in India, rise in heart rate is seen very classically. It is more than 10% of individual will have. So having rise in heart rate, does it mark anything to us in our body? Yes, it invites lot of trouble. What are these troubles? These troubles are this plethora of things. It raises the chances of myocardial infarction, arrhythmias, cardiac remodeling, negative remodeling, ventricular dilatation, congestive heart failure. It progresses towards end-stage heart disease, endothelial dysfunction, atherosclerosis, coronary artery disease, myocardial ischemia. This is a vicious cycle which goes in hand in hand in hand in hand. And the basic reasons are hypertension, diabetes, dyslipidemia, and smoking. Smoking is yet another contributor for sympathetic overdrive in young individuals in India. So thus sympathetic overdrive leads to higher heart rates and greater mortality. If you see higher the heart rate, higher the mortality. So reducing the heart rate, will it benefit the reducing the mortality? Again, this is a topic of discussion. Young Indians hypertensive with higher heart rate have got 3 times higher risk of mortality. This was the article published in JAPI, Indian Journal of Physicians. For every 10 beat rise per minute, there is a significantly increase in mortality and the risk of mortality. So they have proposed a hypothesis. Higher prevalence of hypertension and heart rates in India leads to high CV death. Why CV deaths are very high in Indian and Asians? They have proposed this may be one of the possible pathologies because of which we are having. We are doing the same angioplasties, we are giving the same medicines what Western world is giving, but still, if you are an Indian and Asian, you tend to have higher morbidity and mortality. This is a one step in that particular direction. So thus, they have concluded that higher sympathetic overdrive leads to higher burden of hypertension, higher heart rate in young adults, and higher burden of mortality. So a special consideration whether beta blockers will reduce this has to be thought in. So what does Indian guidelines for hypertension says? The Indian guidelines have made it very classical. The guidelines 4 which was published in JAPI in 2019 and are practiced today says that the diagnosis of hypertension is done when BP is more than 140/90. To diagnose this, not only offers BP, the home BP and ambulatory blood pressure are mandatory. At least 2 out of 3 sittings you should get these things. Patients with comorbidities, BP of more than 130/90 is also considered as hypertension. On ABPM, ambulatory blood pressure monitoring, if BP is more than 130/80, it is diagnosed as hypertension. So one should know these cutoffs also for management of hypertension. Then what is the value of beta blocker as per Indian guidelines? The value of beta blocker as first line agents in hypertension has gone down and it is no more recommended as isolated drug in management of hypertension. It is only recommended when patient have got angina, unstable angina, stable angina, EMI, arrhythmias, heart failure. These are the individuals who are benefit by beta blocker with hypertension type of thing. For routine patients, no longer it is first line management. So prescribing beta blocker only drug for hypertension, only hypertension is not recommended nowadays. Why? What happens if you prescribe? If you prescribe, it has been shown that on head-to-head comparison, diuretics, calcium channel blockers, ARBs, AC inhibitors has got greater mortality and morbidity reduction than beta blocker use in the treatment of hypertension. Especially the all-cause mortality and CV mortality was better with those drugs than beta blocker, which is the third drug after ARBs and AC inhibitors. It is the diuretic which has to be added. CCBs, AC inhibitors, ARB, and diuretic. Treatment of hypertension in elderly more than 80 years, there were some concerns by Western studies. But today we all know that even in Indian population, it is beneficial even if you control blood pressure in elderly. The commonest thing which was found in hypertension in the age more than 80 years was these patients were given atenolol drug in olden days for management of hypertension. They tend to have more and more of ischemic strokes, and the concurrence of ischemic stroke with beta blocker was found. Only then these revelations came further and studies came further which started bisecting with beta blocker what happens, without beta blocker what happens. So today, even in elderly age, the better drug of choice are calcium channel blockers, diuretics, and AC inhibitors or ARBs if tolerated. I told you already, in presence of coronary artery disease, heart failure, antihypertensive must be started whenever the BP is more than 130 by 80, and the goal in them is less than 130 by 80, especially if the age is less than 60 years of age. That these are the targets. Whereas in chronic kidney disease, it is common comorbidity and widely seen in India. One has to treat hypertension very aggressively in renal failure because it not only prevents morbidity, mortality, it prevents progression of renal failure and end-stage renal disease. Is beta blocker used in CKD patients? Yes, beta blockers is used in CKD patient. Which is the preferred beta blocker to be used in CKD patient? The one which are dialysable or the one which are non-dialysable? We all know that metoprolol is non-dialysable. The better drug to be used in CKD is carvedilol. The hypertensive dose of carvedilol is very high. We may be using 3.125 mg, half BD, 1 BD. That is for heart failure. In hypertension, the starting dose is 6.25 mg BD. You have to escalate in 2 weeks to 12.5 mg. And the max dose for Western population was shown to be 50 mg. Our Indian patients may not tolerate so much. Whereas in patients with heart failure with normal ejection fraction, derives significant benefit with good blood pressure control, and when the targets have reached less than 130 by 80. Just like what happens in reduced ejection fraction. So whatever is the ejection fraction, control of blood pressure to less than 130 is beneficial. Who should statins be given? Whether hypertension is an indication for statins, we see commonly some drugs have come antihypertensive in combination with statin. Is it good? Not at all. No statins are recommended for plain hypertension. Only when you get dyslipidemia associated, then it has got beneficial. Prescribing statin with antihypertensive for dyslipidemia hypertension category will prevent not only MI, coronary artery disease, it also will prevent stroke. Our neurology friends are very good enough in prescribing these drugs. They assess the patient, they give the patient. They also prescribe better drugs like AC inhibitors and ARB, which prevents atherosclerosis. So additional benefits can be derived by using appropriate drug in them. Lastly, aspirin. It has got no role as primary prophylaxis in hypertension. In olden days, it was said that take one aspirin to prevent heart attack. It is still true in diabetics, but not in hypertensive. Isolated hypertensive, no role of aspirin, rather it may be catastrophic. So whatever we have told is more theory. Is there any substantial evidence to suggest? Yes, we have got lot of trials. These trials are with various drugs like carvedilol, bisoprolol, metoprolol, and bucindolol. They have been done in heart failure patient. It has been found to have significant benefit in mortality reduction and hospitalization reduction. You can see all p values are significantly improved. The next talk is on this particular topic, so we will just give a passing comment on this. What about nebivolol? Nowadays, lot of nebivolol, the third generation drug, has been pumped in. Nebivolol has got lot of endothelial protection and prophylactic activity. So diabetics, the drug of choice for beta blocker is nebivolol, because the endothelial dysfunction is being taken care at lot of levels. So nebivolol, the trial done was seniors trial. It was done in people who are more than 70 years of age. It was found to be beneficial in them. So it is safely prescribed for these type of patients and even in heart failure patients, elderly patients. What about beta blockers in hypertension? What does the meta-analysis of various randomized controlled trials suggest? It is said that almost 84 trials were seen and the data was pooled, and patients were around 1,65,000 and the conclusions were made. What was the conclusion made for beta blocker? Compared with other antihypertensive agent, beta blocker appears to be substantially less protective against stroke and all-cause overall mortality. So that's why it is not the first line of drug, and that's why it is downgraded by all committees for use of isolated hypertension. However, they exhibit substantial risk reducing ability for all events when prescribed to lower BP with modest or more clear BP elevation with additional pictures. Additional means IHD, coronary artery disease, all those things. I think with these few words, I would like to conclude my talk. The next talk will include specific indications for beta blockers. Thank you. Nikal.
So really thanks for your valuable thoughts on bisofarms, that is curious case of beta blocker. Now I would like to invite Dr. Pritesh Pawar. He is a DM cardiologist, and as you all know, he is consultant at Yashodhara Hospital. So now I invite him to come on the dais and present the case. What's-
Good evening, everyone. Greetings to all of you. I will be presenting bisoprolol and its position amongst other beta blockers. After a very good lecture from sir, we will focus more on bisoprolol and trials related to bisoprolol. So, place of beta blocker in heart failure and coronary artery disease. What are the current guideline recommendations? So, in heart failure, all of us know that it is class 1 recommendation. Every patient of heart failure, HEF-REF patient, that is less than 40% EF, and in heart failure only 3 beta blockers are approved. Number 1 is carvedilol, number 2 is bisoprolol, and number 3 is metoprolol succinate. Only 3 beta blockers have been approved for use in heart failure patients, and it has to be used, and it is a class 1A recommendation as per all the guidelines. Second, HEF-REF patient, it reduces the risk of hospitalization and death. We are more worried about repeated hospitalization. We know heart failure patients, they get repeated hospitalized, and beta blocker reduces the repeated hospitalization and it reduces the mortality. In coronary artery disease, again it is class 1A recommendation. In angina, first line treatment with beta blockers. All beta blockers can be used in coronary artery disease, unlike only 3 beta blockers which can be used in heart failure patient. So pharmacological properties of commonly prescribed beta blocker. Second generation, as already sir told, they are cardioselective beta blocker, bisoprolol, metoprolol, atenolol. They don't have any intrinsic sympathomimetic activity. Bisoprolol, half-life is 9 to 12 hours. So advantage is once a daily dose, which can be used with bisoprolol. Atenolol has a half-life of 6 to 9 hours. Problem with atenolol is last 6 hours, if you are using atenolol only as a OD dose, last 6 hours your patient will not be protected from the hypertension management which you want to use. So atenolol, all the trials, earlier trials were done with atenolol, and they have shown that atenolol is inferior to other beta blockers and atenolol is inferior to RAS inhibitors, calcium channel blockers. Third generation is cardioselective plus additional vasodilating properties, carvedilol and nebivolol. So pharmacokinetic advantage of bisoprolol. Half-life, as I have already told, 9 to 12 hours. Absorption is more than 90% and 50-50% hepatic metabolism and renal excretion. It's 50-50%. And it is having the maximum beta 1 selectivity, 75 times more selective on beta 1 receptor as compared to beta 2 receptor. So these are the advantages: highly beta 1 selectivity and 50% hepatic metabolism and 50% renal excretion. So that is a balanced excretion and highest beta 1 selectivity. So here we can see mechanism of action has already been discussed by sir. Decreased heart rate and cardiac output. We all know juxtaglomerular apparatus has beta 1 receptors which produces renin. So beta sympathetic activity also increases renin, angiotensin, aldosterone activity. So beta blocker also acts, and they are decreasing renin, angiotensin and aldosterone system levels in the body. So here we can see it is the maximum beta 1 selective beta blocker, and dose is 2.5 to 10. 1.25 is also available, 10 milligram. So dose, anti-hypertensive dose is 5 to 10 milligram. If you want to use bisoprolol as an anti-hypertensive agent, the dose recommended is 5 to 10 milligram. This is what it is approved for use as an anti-hypertensive and in coronary artery disease in UK. But in US, it is not approved for use as an anti-hypertensive. 1.25, 2.5, these are the doses which we use in heart failure patients. Other drugs we can see. Now selective beta 1 antagonism, comparison of beta blockers in heart failure. So initial sir has shown you a lot of trials. Here we will be specifically focusing on trials on beta blocker molecules. Carvedilol, bisoprolol, metoprolol used in patient with heart failure and COPD. Patient is having COPD and patient is case of heart failure. So here we can see hazard ratio of bisoprolol were statistically significantly lower in most of the subgroups, suggesting an independent role of bisoprolol in patient survival. So if 3 groups, one group was given carvedilol, one group was given bisoprolol and one group was given metoprolol, all patients having heart failure with COPD, mortality was less in bisoprolol group. This is what is inferred from this trial. No survival benefit with carvedilol and metoprolol as recommended by the heart failure guidelines. In patients with coexisting heart failure and COPD, a dose response survival benefit observed with bisoprolol use but not with carvedilol or metoprolol use. This is what sir had also explained, that is in operative patient, post-operative patient, bisoprolol had less strokes as compared to atenolol or metoprolol. Perioperative metoprolol increases post-operative stroke. What was the mechanism? We all know beta 2 receptors, they causes vasodilatation, and these have additional activity on beta 2 receptor, so that beta 2 receptor mediated cerebral vasodilatation was attenuated, and that was responsible for most post-operative strokes in patients who were on atenolol and metoprolol. So they concluded that highly specific beta blocker was associated with reduced risk of post-operative stroke compared with less selective beta blocker. And what patient population they have taken? 50 years or more having non-cardiac and non-neurologic surgery. These patient population they have taken. Number you can see 44,000. Metoprolol and atenolol is associated with increased risk of post-operative stroke compared with bisoprolol. So if the patient who is undergoing surgery and he is on metoprolol, atenolol, chances of strokes are more as compared to bisoprolol. Then this is a tenacity study. Here, this is a real-world clinical performance of bisoprolol in post-MI patient with LV dysfunction. This study is from India only. This study is from Ahmedabad. So here, post-ACS patient with left ventricular systolic dysfunction, HEF-REF and HEF-MREF, that is 40 to 50%, mid-range ejection fraction. HEF-REF is less than 40%. So here, this was a study which was non-intervention, single center and retrospective study. What they did, they collected the data, 1 year data of patients who were on beta blocker, specifically bisoprolol, and what was the primary outcome was change in left ventricular ejection fraction. And they found that there were patients who were given beta blocker and specifically bisoprolol, they had improvement in left ventricular ejection fraction from 41 to 48%, with significant reduction in heart rate. The secondary outcome was change in heart rate and lipid profile, HbA1c, and ST segment deviation of J point at 1 year, without adverse effect on lipid and HbA1c. So bisoprolol, and one more thing which they saw was NYHA class. There was improvement in NYHA class, there was improvement in left ventricular ejection fraction, and there was reduction in heart rate. So bisoprolol administered along with other guideline directed medical therapy in post-ACS patient with left ventricular systolic dysfunction significantly improved LVEF with significant reduction in heart rate and ST deviation at J point at 1 year without adverse effect on lipids and HbA1c. So this was the inference. Next indication is in angina. What is the real world evidence? This is a study from Italy and Germany. What they have done from 2000 to 2014, 14 years data they have taken, and they have seen patients in 3 groups, one with bisoprolol, one with other beta blockers, and one with drugs other than beta blocker. And here, what they have studied is effect on mortality. And in that 3 group, what they found, the patients who were on bisoprolol had decreased mortality as compared to patient in other beta blocker group and in patient in non-beta blocker group. So significant reduction in mortality, here you can see. Protective effect of bisoprolol in terms of mortality remained significant during the follow-up time. So this was 14-year study. Again, lowest incidence of mortality, you can see bisoprolol is red, then other beta blockers and drugs other than beta blocker, there is non-beta blocker. Again, CV outcomes we can see in the form of embolism, secondary angina, myocardial infarction. Again, CV outcome as compared to other beta blockers and non-beta blocker, bisoprolol performed well. One more indication which sir told in his talk was hypertrophic cardiomyopathy, obstructive. So there is a study, this was a retrospective study where you can see the patient with hypertrophic cardiomyopathy, obstruction, gradient more than 50 and NYHA class 2, class 3 were taken, and they were started on bisoprolol 1.25. And what was the endpoint? That you should achieve a LVOT gradient less than 30 and you should improve, patient should have improvement in NYHA class. So this was the primary and secondary endpoint. So treatment with bisoprolol was well tolerated and effective in relieving obstruction and improving symptoms in a significant proportion of patients with symptomatic obstructive HCM. So in these patients also, bisoprolol is safe. So efficacy is proven. You can use bisoprolol in hypertrophic obstructive cardiomyopathy. So my final slide, take-home messages are bisoprolol has highest beta-1 selectivity among all beta blockers. In patient with coexisting heart failure and COPD, a dose-response survival benefit observed with bisoprolol use, but not with carvedilol or metoprolol. Metoprolol and atenolol associated with increased risk of post-operative stroke compared with bisoprolol. Then bisoprolol in post-ACS patient with significant LV dysfunction causes significant reduction in heart rate, improved left ventricular ejection fraction, and ST segment deviation at J point at 1 year without adverse effects on lipid and HbA1c. And treatment with bisoprolol is well tolerated and effective in relieving obstruction and improving symptoms in significant proportion of patients with symptomatic obstructive hypertrophic cardiomyopathy. Thank you for your patient listening.
Thank you, sir. Thanks for your valuable inputs on beta blocker, sir. Now, if there are any questions, we can take the questions. So I think we will close the session now, and really thanks from the bottom of our heart as an organization. We will thank you all of you for coming down for this Bisoform Symposium. Enjoy your drinks and dinner. Thanks. Just one, we want to facilitate our guest. I request Agrawal sir, please facilitate Dr. Rizwan Ulak. And I request Maske sir to facilitate Pawar sir. Thanks all of you. Please enjoy.